to a blank screen with two initials of your name on it. Alors, bonjour à tous, bienvenue à la présentation scientifique d'aujourd'hui. C'est un plaisir pour moi de vous présenter Dr. Tracie Barnett. Dr. Barnett est professeure agrégée au département de médecine familiale et chercheuse au Centre de recherche de l'hôpital Sainte-Justine. C'est la directrice scientifique de l'unité de soins SSA expertise complémentaire. She's also co-director of the McGill Partenariat Patient Public and co-director of FRQS, Network on Cardiometabolic Health, Diabetes and Obesity. Dr. Barnett s'intéresse dans sa programmation de recherche à l'histoire naturelle de l'obésité, et des comportements qui sont associés et des conséquences métaboliques, ainsi que de l'environnement quotidien et de l'impact et de l'interaction de tout ça au niveau des habitudes de vie. She's developing strategies with collaborators, including clinical and patient partners, to promote cardiovascular health by leveraging individual and environmental resources in primary care settings and in the community. Most importantly, thank you very much, Dr. Barnett, for letting us know that you have a cold and keeping that at home with you. It's a pleasure to have you through virtual mode today. Alors, I will pass the mic on to you. Does anybody know if I have to mute here? Let's just mute it here and...
Okay, it appears muted. Thank you so much for the invitation, and I do apologize. It just did not seem responsible to come or perhaps present with a mask or something. So I'm glad we have this option, and I appreciate your cooperation and understanding. Yes, so I will start right away, but please do interrupt me if you have questions or you want clarifications, and I'm hoping to leave some time at the end for some questions and discussions. I think the original invitation had to do with this team grant that many people at St. Mary's and in the family medicine and elsewhere are team members of. And at this, it is very much in the initial stages. So I'm going to be presenting a lot of the foundational work that led to that and some of the initial work that's being done, but you'll have to invite me again to get the results of the particular GACD project because we are in the initial stages. And even better would be to invite the trainees that are working on this. All right, so without further ado, I would like to start by acknowledging that McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. And we acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. And I have to say, I feel very privileged in family medicine that we have a strong network of Indigenous researchers, and I feel very privileged to be able to learn from them. So this slide captures my program, if you will. So I like to present this first, defining environments. By the way, can you see my cursor?
Yes.
If I move it around? Okay, just to be sure. So it really captures my program where I try to define environments like neighborhoods here or activity spaces, you know, how would you circumscribe where you spend your day, capturing all sorts of exposures, whether it's noise, social disorder, for example, built environment. This could also be perceptions, satellite images, data from geographic information systems like this, and then assessing and defining outcomes. Oh, I think you can also see this. Can you see the window? Because I have this captured. I have a lot of participants that I can see on my screen, but if you don't see them, that's good. You don't see them? Okay, that's good. Still going to minimize it because it's a little bit it's funny, I can't minimize it. Okay. So in this particular model, you see things like physical activity as mediators. These are the types of outcomes I'm interested in, though. So this model generally just illustrates that I'm developing indicators, I'm describing things, testing relationships, and sometimes trying to identify mechanisms. So in the next slides, I'm going to present some of the key evidence linking the built environment with our health behaviors and health outcomes, along with some salient methods, such as the approaches for assessing built environments. I'll share some examples from some student-led research, and I'll also describe the quality cohort in particular, because it was the data infrastructure for much of this foundational work. And I'll finish with the most recent team grant, which is all about translating this largely observational body of work, along with other evidence, to try to achieve some real actual clinical and community benefits. So why study neighborhoods? Well, they can look like this, or they can look like this, with quite different impacts on health behaviors. Now, this is computer generated, but we can also improve neighborhoods, making them more conducive to physical activity, social interaction, and so on. And so, like this, the point is that neighborhoods are dynamic and they can be characterized many ways, including by features of the built environment. So if I take a more formal model, the one developed by Larry Frank and colleagues, these would be the features here in the environment and travel bubble here. These are the ones that really interest me and that I've focused a lot of time on. So it includes aspect of transportation infrastructure, land use, and walkability, meaning, how varied are the purposes of the spaces and the buildings, how much green space is there, is it mostly residential, et cetera. Can you live car-free quite easily? So these factors impact our behaviors, making it more or less easy to be physically active and eat healthfully. Impacts our exposure to environmental pollutants, including air particles. And this, in turn, influences various biological responses and overall physical and mental health. So note again that I will try to incorporate physical activity as an outcome whenever I can. So there are certainly plenty of studies and even reviews out there investigating the links between built environment features and health outcomes, and I will illustrate some. A term that comes up a lot in the built environment literature is walkability, where highly walkable environments would be like these on the left here. They have greater mixed land use, they are denser, and they have shorter and well-connected street segments, generally is how you would describe them. And there are many such examples in the literature. In this study of thousands of Ontario neighborhoods, the prevalence of diabetes decreased over time for residents that lived in high walkability neighborhoods, but remained the same in low walkability neighborhoods. Relatively crude indicators, but it is something that's worth exploring. And in this study, moving from a less walkable neighborhood to a more walkable neighborhood reduced the risk of developing hypertension by 54% compared to remaining in a low walkability neighborhood. So this actually involves a change in your environment. Now, there aren't that many longitudinal studies, so very few have reported this kind of result, but how neighborhoods change and what those most salient features are for the desired health outcomes or health behaviors. That's an important focus. So this was always a particular interest to me as part of the quality team. And I'll describe that briefly very, very soon. It's an ongoing cohort study of the natural history of obesity and type 2 diabetes in a cohort of families. Now, let's see, just have to move this forward. So I also listed social networks as another area of research of mine. So it's easy to understand that the built environment is very closely linked to the social environment. I just want to give a little bit of the theory behind it. So the social environment, it's often defined by aggregate characteristics of the residents of a neighborhood, such as area mean or median or median income rather. And the social environment also includes the type, the quality, and the stability of social connections. We sometimes refer to social capital, a sort of collective efficacy, which includes feelings of safety, belonging, for example, but it stands to reason that neighborhood design can enable or encourage social cohesion, trust, and community connections. So it seems that I would be remiss in not incorporating it in my program of research. So just to show some of the evidence linking social environment and social networks, this is a study of adults with more close-knit relationships. So those that had more friends that lived nearby, a larger and denser network, had healthier diets. They were more physically active. They were less sedentary. Now, of course, the mechanisms are also of interest. This is somewhat superficial look at this, but in fact, in this particular study, they did expect that it would be mediated by social support, but it was not. However, this was a cross-sectional study. And in this study, though, they did follow them for 10 years, a 10-year observational study of older adults looking at social networks and the incidence of diabetes-related dementia. And they observed that having a larger and richer social network reduced the risk of dementia and could buffer somewhat the effects of diabetes on the risk of dementia. And, and in this study, looking at social network features and progression of diabetes, a smaller network size was associated with more diabetes-related complications. And in this case, it was suggested that possibly that small network reduced the opportunities for getting additional informational support, for example. And finally, in this study, which is a rare actual social network intervention study, patients with diabetes were asked to recruit peers from their existing network, and the intervention was designed to reinforce group cohesion and make it more supportive. And so we see here that the friends and relatives led to a greater improvement in diabetes. Or possibility interventions. So that's just an overview of some of the more, I think, convincing literature that motivated a large part of my own program of research. Now, because it was such an important part of the BEACH lab, I do like my acronyms, Built Environment and Community Health. I'll describe the quality cohort briefly, because it was really at the origin of everything. And there were 600 families that were recruited through schools, almost entirely in Montreal, a few in other cities. And the neighborhood study was one of the first add-ons to this quality. So the ones in red here are the ones that I've led, that I've been responsible for. And I'm going to focus primarily on the first two, neighborhoods and personal social networks. Now, these families had children considered at risk of cardiovascular disease because one or both parents were living with obesity. So what did this infrastructure allow and support? Well, certainly a development of tools to assess the built environment. This was an important part of the whole program. So one PhD student in particular developed a park features assessment, and I'm really just giving a couple of examples because there are quite a few that you can find if you Google quality. And a postdoctoral candidate trained in criminology with an interest in perceptions of safety also used quality to validate a method assessing nighttime light. And this was in collaboration with the International Space Station. In this particular example, a medical student over a summer internship validated a desk-based tool for assessing what I would call the obesogenic potential of neighborhoods. So we did a lot of on-site audits of neighborhoods, very detailed street-level audits, and he validated a Google Street View version of it. Let's see here. So, but before this Google Street View approach was validated, again, we would go on site to do the audit. So we would trace a walking buffer around each residence of each participant, and trained teams of observers would complete detailed audits of 10 street segments connected to the residence, then a more general observation of all street segments within the 500-meter walking network, up to 3 nearby parks or green spaces. And we assess things like the presence and quality of a walking, cycling, rolling infrastructure, dedicated walking lights, narrowing of lanes, stop signs, etc. Also looked at things like disorder, graffiti, abandoned buildings. Maybe in all about 50 different characteristics that we looked at. And so we did conclude that we could use Google Street View quite easily to capture pretty much the identical features that we were doing on site. And then once we would audit these, we created indicators so that we could actually use this in our analyses, and in particular to try to relate them to some health behaviors and some health outcomes. So to measure, pardon me, I don't know why this is not moving very well. So we looked at the data many different ways and arrived at 3 summary indicators that really best characterized the neighborhoods. And these actually emerge across many of our papers and different analyses. Pedestrian aids, which would include things like zebra crossing, textured street coverings, dedicated lights, sidewalks, both the quality and the width. Then we also had traffic calming measures, which included things like speed bumps and obstacles, single driving lanes, restrictions, to really try to narrow those lanes, and neighborhood disorder with specific street level elements, but also general perceptions. Now, we also reassessed this again over time. So we were in dedicated neighborhoods that we were sort of monitoring over time. And just a little glimpse, this was some work that was led by a master's student at the time, just looking at change, like how much do neighborhoods change? This is only over 7 to 8 years, approximately 25% either experienced an increase or a decrease in some kind of exposure. So you see about 75% didn't really change, but we saw over time, sometimes it improved and sometimes it deteriorated. And in particular with the neighborhood disorder, that increased over time, about 50-50 for traffic calming measures, and things did improve with pedestrian aids. And many of us did notice some improvements in our neighborhoods over time. Oh, pardon me. Right. Okay. So this is, I already mentioned this. So then this infrastructure, of course, was used a lot to identify risk factors and just understand the etiology, not just of obesity, but also its behavioral antecedents and also the metabolic consequences. But one of the papers that I led actually was looking at trying to characterize again the Montreal neighborhoods based on these indicators that we found, and tried to examine their associations with a range of outcomes. So you can see here color codes that indicate those constructs that emerged as most discriminating between neighborhoods using only these built environment features. This is really only the built environment, a little bit of the social environment as well, but there are no individual level measures here. And there were 5 types of neighborhoods that emerged based on our audits. They really had contrasting built environments within that 500-meter walking network, which is how we define neighborhoods. They can be defined a number of ways, sometimes census tract, dissemination area. We really had it what you call egocentric around the home of the participant. As an example, some participants would have no depanners or corner stores within that 500-meter walking network, and others had 8 to 10. They could be very different. So the most striking observation was that participants that resided in neighborhoods that had the most vehicular traffic, or so they normally is because they live near highways and very busy roads, they were the most likely to experience an increase in adiposity over time. And this is, of course, controlling uh, for the known risk factors, the parental propensity, socioeconomic status as well. So neighborhood environments will, of course, interact with other levels of influence, including individual and family levels. So this work was led by a PhD student at the time. She is now professor in School of Nursing. And she combined several domains of influence, including individual, family, and neighborhood. And the idea here was to identify the most discriminating factors. It was sort of an early use of machine learning approaches. It was called a recursive partitioning approach. So what were the most discriminating factors that predicted the development of obesity? Then the next most discriminating, and so on. And we see here, maybe not surprisingly, that parental obesity and physical activity were the most discriminating, but soon after followed by area disadvantage, access to parks, and access to convenience stores. And of course, we're getting into small numbers when you start decomposing more and more, but those that would experience all of those adverse exposures had a 60% chance in this cohort of developing obesity. So finally, one more example of the type of work emerging from this infrastructure, linking perceptions of safety to the development of obesity. And this is Dr. Côté-Lucier, and her work continues today exploring how environment affect our moods and subsequent behaviors. So I mentioned the social networks project as well. But first, let me I get the take home of what I've just presented now. Is, what we can conclude is that neighborhoods can and do change even over relatively short periods of time, which means that it's an interesting target for intervention. And that from our relatively simple studies, even minor neighborhood enhancements, and specifically adding traffic calming features, may impact levels of physical activity favorably, and should be considered as intervention targets. Again, I didn't show you everything, but we looked at specific outcomes like behaviors, sedentary behavior, fitness, physical activity, and also physical inactivity. So who was least likely to be active? So, okay, as I said before, I did mention the social network project, so I'm going to pivot to that because it is also an important aspect of any physical activity promotion efforts. I hope that I'm just exposing you to a range of things that could be leveraged when we're doing trying to promote physical activity that is tailored to your built and social environment. So broadly, networks contribute to social capital, which Putnam describes as the social networks and interactions that inspire trust and reciprocity among citizens. So social capital at the individual level. Oh, I see. I have some animation here. I apologize. Social capital has been described as the resources that are embedded in one's personal network of social ties. That's the connections and the contacts with other people, includes significant others, and this group would normally be an important source of social support. Now, the mechanisms are unclear, but we know that grafting social support generally fails. It's difficult to bring in some extraneous social support. It's not impossible, but it does work better if it's possible to emerge from within your own, or activated from within your own network, if at all possible. Now, sources and appraisal of social support is a key pathway to social ties, from social ties to health. So social network analysis could be a useful tool for exploring the structure and characteristics of the core relationships, to understand the dynamics between social support and outcomes, and identify mechanisms and mobilize that social support. So I just like this illustration by some of you might recognize this is the Dunbar, an anthropologist. So there's an idealized circle of acquaintance and personal social networks. And there's a theory that says that there's a maximum number of personalized, meaningful, reciprocated relationships that we as humans can maintain. And it's due in part to the behavioral complexity of relationships, time constraints, but it is supported by studies that look at group size as a function of the ratio of the neocortical volume to the total brain in primates, brain volume in primates. So basically, it's all our brains are wired to handle. Are there any guesses? And you could just speak up or put it in the chat if you like, as to what that number is. Some of you may have already been exposed to this somewhere. What is the number of personalized, meaningful, reciprocated relationships? It doesn't mean you're close best friends, but you know each other's names, and this is someone that you see at least on a somewhat regular basis that you can maintain. Anybody know what that number might be? It's emerged as, some of there was like the ideal number for certain villages centuries ago. It's often the average number of Facebook friends. It's a number that comes up quite often. No guesses? While you're thinking about it, let me know if this is more or less than you thought. Did someone say something? Oh, it looks like Marion knows.
We have 200 here from someone in the room, and we have Marion suggesting 5, I think.
Oh, 5, that's the close, tight network. But 200 is not bad. It's apparently 150. That's the number of friends. And the idea is that if somebody new moves in, somebody old moves out, because you can't really support more than that. It's a bit of an aside. I just find it's a fun little tidbit that appears to be, solid. So the entire network of reciprocated meaningful ties is thought to be about 150, but you would look towards the core here, the 20 people or so as the support clique and the sympathy group, it's called, because this is probably where you would want to get your social support, emotional support, if you're trying to tailor or leverage some kind of social capital or social resources within your network. And just trying to characterize what that might look like. So there's certainly a lot of evidence to support the idea that our social environment influences our choices, both positively and negatively. But this is the evidence which led us to develop this study within quality, in which we're measuring not only how built environments here, this is the BE, the built environment changes over time. So we have 4 cycles. We're measuring the personal social networks over time. We're measuring a whole bunch of psychological, emotional, cognitive factors as well, and lifestyle behaviors. But my interest being often in the built environment is how might that support or facilitate the creation these social connections, and how they together might influence lifestyle behaviors. And right now we are between the cycles 3 and 4. A master's student, Tanis Nelson, has already used the baseline data for her own work, and I do have some early preliminary findings to show, because it's I think it's quite interesting. So we have monitored and measured the personal social networks of our quality participants over time, trying to characterize them. Like, what are the phenotypes of these networks? Now, I don't have the animation here, but essentially there were 5, again, distinct types of friendship groups, personal social networks that emerged. And there's a lot of information here, but essentially, if you look at cluster 1, which is the red one, like the more you're on the outside, the more you have a high number of that particular construct. So some of them had a high proportion of alters, or that's the people they're tied to, that had healthy diets, that were active, that encouraged them to be physically active, that did physical activity with them. And then, we also had networks where there was very low numbers of that. They have very different numbers of total number, like the size of the network would change a lot. The proportion that you felt close to, the proportion that were new friendships as opposed to lifelong friendships. And the same thing with dietary outcomes or behaviors. And also how well is your network connected? Do all of your connections know each other, or are they all sort of isolates, independent? So using a kind of automated approach, these were quite distinct. And what was interesting, though, is that they were very strongly associated with the predicted probability of either being active or inactive, or having a healthy diet or not, and much more strongly for physical activity. That's the first thing that emerges. Now it's just a cross-sectional analysis. Now, not only were there the types of personal social networks that were associated with health behaviors, as we saw, but there were very strong differences in terms of motivation and competencies. It's a heat map here, just so down at the bottom we have the clusters, and this is the correlations with certain mechanisms that you might think are implicated in whether or not you do a certain behavior. And this also was very strongly associated with these clusters. So I'm only just starting to appreciate all these psychology constructs that are underpinning behavior change. So I won't go into too much depth. I will revisit it a bit, but this really points to some opportunities for intervention. And I should say that I have started my sabbatical, and I'm exactly going to be doing this at University College London with Susan Mickey to try to better understand these behavior change constructs. It's called an ontology, anyway, and leading to behavior change techniques as well. So when it comes to physical activity promotion, we need to think through what needs to change. So it's extremely helpful to use a framework like Susan Mickey's behavior change wheel. So if you look at the levels of the intervention, so I'll have more to share again when I return from my sabbatical. But essentially, the idea is that there are 3 ingredients that are necessary to any behavior change, which you see in green here. You need to have the capability, the motivation, and the opportunity. And this is true for citizens, healthcare providers, policymakers. This can really be at any level that we're interpreting this. Now, the red portion shows the broad types of intervention, so that all of this can be imagined to spin. It can be things like persuasion, environmental restructuring, which I'm interested in, of course. And the outer shell, the gray, would show the policy category. Intervention could sort of be brought forward. So now these are quite broad, but it's a good starting point, and it's essential to think through and develop, eventually leading to very specific behavior change techniques, which is again what I will be doing in London with the team over there. So as a quick example, I recently became aware of this Parks prescription program. It's an initiative driven by healthcare professionals who want improve their patients' health by connecting them to nature. It's a simple idea that requires there to be safe, accessible parks or other open spaces, of course, but also that healthcare professionals have the capability, motivation, and opportunity. And should such an intervention be offered, that the patient also has the capability, motivation, and opportunity. How you get there is something that really has many steps and has to be thought through. So if you look at it, this is in fact, an intervention that targets healthcare providers. And even in this sort of brief summary, which is trying to explain the benefits of using this type of Parks prescription approach, we can see that there are many specific behavior change techniques that are being invoked, things like persuasion, invoking social norms, enabling tools, instructions on delivery, etc. So this is quite new to me, having been trained as an epidemiologist. When you come to try to apply something and think about interventions, you really have to think through. It's not just, oh yeah, we'll just make sure we'll tell them to be more physically active. how exactly are you going to do that? There's a lot of co-design and thinking involved if you want to have something that's appropriately implemented, delivered, and everything. Yeah. So finally, coming to this project that I'm doing with so many here at McGill and elsewhere. So in particular, I should name them. There's at McGill, I'm doing this with Sylvie Lambert, Anita Kushik, Elena Adams, Tibor Schuster, also have Paula Bush, Tamara Carver, Belinda, Nicolau. Couldn't do this without Abdul Kadri. He recently completed his PhD, so I'm very fortunate that he's working as a research associate on this. I have a patient partner, Sonia Lucier, and there are many more for other universities, and I have to mention Simon Bacon and Kim Lavoie, who are co-PIs, and crucially, Dr. Victor Mowbray, who is my counterpart in Ghana. So the idea is that the origin story is exactly a series of failed chair applications that in the end became an opportunity to propose a project with some partners in Ghana that we were fortunate enough to meet because we'd been working the year prior on a different project that we decided not to submit, but we started, we developed a good relationship, trust, and had very similar interests. But you can imagine that we're doing this in very, very different contexts, however. The idea is to promote physical activity in primary care settings, which includes the broader community as well. And what is the process of getting to something that could be effective, that could be implemented, and ideally could be scaled up? So I am part of a very large team here, brought in a lot of expertise because this requires a lot of expertise, and we're getting somewhere. So the idea was, we argued that primary care providers were ideally situated to identify people at risk of NCDs. They're known and trusted by patients, and physical activity counseling by primary care providers has been shown to be effective. This was the starting point. But we also, so we then started with a preliminary workshop, which was funded by a planning grant, CIHR, and also the CMDO. The idea was to co-construct a strategy, a protocol for moving forward. And we ended up with a lot of stakeholders. We had clinicians, we had patient partners, of course, researchers, behavioral scientists, communication experts. So we identified the implementation barriers and facilitators and identified the features of effective physical activity interventions. Generally, it should be brief, tailored, have a very prompt follow-up, and there should be specific goals that are together. It's a bit of a broad starting point, but we weren't starting from entirely from scratch. So what we identified, or what we know, are the main implementation challenges. Actually, when you don't involve stakeholders or interested parties sufficiently, it's not sufficiently tailored. You're not using. It's not grounded in behavioral science, and you're not taking the reality of your day-to-day clinical setting into account. And this is what we are, solutions to this is what we're trying to develop together. And we very, in a very summary way, there's 4 phases. We're co-adapting the intervention, not only a kind of protocol that would be co-adapted across different contexts here, but between Montreal and Tamale as well. And we are now we're still in phase 1. This is a very long. So we have something that we're ready to pilot. We'll test the effectiveness of the intervention and its implementation. Then the idea is to have a subsequent many qualitative portions here that would allow us to end up with strategy, but that's further down the road. For the moment, we have 7 working groups, probably more by now. Actually, all of them are working on the co-adaptation. We need all of these groups and brains working on this to try to move forward. Every single group has a co-lead from Ghana and from Canada. I'm not going to go into too much detail here, but in summary, we have our initial PEP design. That's what we're calling our intervention, which is prescribing exercise in primary care during the physician encounter. There are multiple literature reviews. There's been a lot with patients in several clinics in Montreal. We speak with clinicians. We are in, and we have started doing some analysis there. All of this is student-led work that really wouldn't get done without them. We have, in addition, some stakeholder consultations that have happened in Ghana. And so it's really a very intense data collection phase where we're going to bring all of this together before we propose something that would make sense both in Montreal and a process that can be adapted in Tamale and vice versa. So we're working with different contexts, but the consultation process is actually not that different. And in fact, I hope it'll work. No question that context is crucial. We did have a couple of meetups in Ghana and in Rwanda during the broad GACD Global Alliance for Disease team meeting, and I have a team of students that put together a little promotional, a little video that illustrates what we're trying to achieve. I shudder the patients have brought forward. They were interviewed, and it's the students that together. So I'm going to stop sharing this one and share this, and then I'll be very happy to take your questions. I hope I can stop sharing. Yes. And let me see if I can find this here. What is that? Okay, I'm going to try to share again. I'll try to share the correct video. And I'm going to try this one more time. I'll move this over to the other window. Send somebody the link. Okay, I think that's it.
Movement is part of daily life in ways we often overlook. We asked
Can you
people
hear it?
in Montreal, Canada, to show us what through their own photos and stories. We explored how movement takes shape in everyday life.
The road is clean. It encourages me to do exercise. I can just walk. For me, being in the water and swimming and hearing the bubbles, it's exercise, but it's also very meditative.
The bicycle I always use it as my daily activity. That is my transport.
My bicycle is for transportation.
A bottle that I've added some SAM in it to make it heavy so that I can use it for my training. Walking in nature is really something that I absolutely love.
So this project is about figuring out together the process of helping patients, communities, just people in general, become more physically active.
So at the end, we want to see how we can promote or we can encourage individuals to follow physical activity or to participate in physical activity using their community environment.
How the picture makes you feel.
Yeah, I feel good because if looking at a picture like this and I'm able to use it, I'm doing it.
Those pictures, it tells me to what? It serves as motivation to me. It tells me to do something.
Spaces like this are really important because it's in an urban setting, and you've got this little, like this pocket in the middle of it.
Non-communicable diseases are on the rise and remain the leading cause of death worldwide. Physical inactivity further fuels this crisis. It's time for a global conversation. How can environments help us do so?
All right, I will spare you the last image of me. So that's it. I hope I was able to convey some information, some novel information about assessments and importance of the built environment. I'm glad that my drugs are hanging in there. And I'd be very
Merci.
welcome.
Merci beaucoup, Dr. Barnett. On va ouvrir aux questions.